Hello and welcome everyone to our third Global Neonatal Journal Club. Welcome also to Shiraz and Julie, if you're there, the co-hosts for today. Thanks so much for joining us from all around the world, from the UK across to New Zealand and everywhere in between. I think we've had around 500 registrants for this session today, and we're really excited to see those of you who can join us live. Just trying to get to the next slide. There we go. As usual, we've got representatives from a whole lot of countries joining us today. It's absolutely brilliant to see just how great the representation is from around the world at all different times of day and night. So thank you. That's across disciplines as well. Whilst the majority of the audience has been neonatologists and neonatal nurses, it's great to see a smattering of all different types of disciplines joining us here for these journal clubs. Before we go too much further, I just wanted to acknowledge that next Monday, 17th of November, is World Prematurity Day, and for us that's a really special day. Those of us working in NICUs, for people with lived experience, and for all of us looking after premature infants either in the first days of their life or into childhood. It's just such an important time, and I know there'll be many of you having special occasions for that day, and so we acknowledge that next week is a big one for all of us. We love looking after premature babies, and we hope that these journal clubs are really bringing us all together to improve outcomes for premature infants. Your hosts are Julie, myself and Shiraz as usual, but we've got a fantastic panel online waiting to join us live for our Q&A session, and that includes Professor Peter Dargaville from Hobart in Tasmania. You'll know Peter, a well-established, world-renowned clinical trialist in respiratory medicine in neonatology and the principal investigator of the Optimus trial of minimally invasive surfactant therapy, amongst many other things. So it'll be fantastic to hear his thoughts on this paper today that we're presenting and the context of it. And we've got Professor Neena Modi joining us, normally from Imperial College in London, but joining us live from Singapore today. Neena needs no introduction. Again, a world-renowned clinical trialists in so many fields of prematurity and clinical research in neonatology, and it'll be fantastic to hear her thoughts on this paper as well. We've also got a special guest today, Lucy Loft, who you'll meet shortly, who's our first neonatal research fellow here at Mercy Perinatal in Melbourne, who's going to be reviewing the paper today. This is the paper we're reviewing today, Early Intratracheal Budesonide to Reduce Bronchopulmonary Dysplasia in Extremely Preterm Infants, the Budesonide in Babies, or BIB, randomised clinical trial by Dr. Ambal, as we all like to call him, as his friends know him. And I'm going to pass over now to Lucy Loft to review the paper for us, after which we'll have an interview with Dr. Ambal himself and then the Q&A session. So we look forward to your participation. Please put your questions into the chat. We'll be monitoring the chat as we go along, so don't be shy, and we'll answer as many as we possibly can at the end. So now we're going to pass over to Lucy Loft. Lucy.
Perfect. Thanks, Brett. I'm very excited to be here today, so thank you for the introduction and to be able to present this exciting paper to everyone. So a bit of background to start to the BIB trial. Bronchopulmonary dysplasia, or BPD as we know it, has slightly varying definitions depending on which one we choose to look at, but however is a chronic respiratory condition of prematurity with potential lifelong consequences for respiratory well-being, affecting approximately 45 to 50% of extremely preterm infants. It's also been associated with adverse neurodevelopmental outcomes long-term, and is also contributed to by inflammatory changes. This inflammatory process led to the premise of some of the systemic steroid trials that have existed so far, with some promising use of steroids in infants at less than 7 days of age in showing reduced BPD or death. However, there's also been associations with the systemic steroid use with gastrointestinal perforations and cerebral palsy. So if we have some of these systemic side effects, then the question remains, how can we deliver targeted anti-inflammatory medications, and in this case, steroids or budesonide, to the lungs? And thus, intratracheal budesonide trials were created. So what do we know already before this trial had started? There have been a few smaller trials that have led to two very large randomised controlled trials, which have included the BIB trial. And the first one I'd just like to talk about is by Lee Oei from Taiwan, who's been a leader in this area. The first one was in 2008 in Taiwan, which was a single centre trial. It was a prospective randomised blinded trial in 116 very low birth weight infants of less than 1,500 grams who were mechanically ventilated with severe radiographic respiratory distress syndrome and who required more than 60% oxygen after birth. 60 infants were in the treatment group and 56 were in the control group. And both the budesonide was at a dose of 0.25 milligrams per kilo, which is the same dose that you'll hear across all the trials spoken about today, and was given with 100 milligrams per kilo of Surfactante as the surfactant choice in this trial. This was given every 8 hours until the oxygen requirement was less than 30%, up to a total of 6 doses, with the median dosage between 1 and 2 doses in this trial. The endpoint assessment was the number of infants who would either die or develop chronic lung disease at 36 weeks post-conceptional age. And this study was really promising. It showed a decrease in death or chronic lung disease at 36 weeks from 32 down to 18% and was seen to be a very promising pilot study. And this led on to another big trial by Oei, which was published in the New England Journal of Medicine in 2016. And this was conducted between 2009 and 2013 in 3 tertiary centres in the US and Taiwan. And this one was more than double the size, so 265 infants. Also a very low birth weight, less than 1,500 grams, with the same dosing and the same medications as in the previous trial. The criteria or eligibility criteria was slightly less oxygen requirement, so with an FiO2 of more than 0.5 within 4 hours of birth and requiring mechanical ventilation. This group had a slightly younger cohort, so with a mean gestational age of 26.5 weeks and a slightly higher in the control. And this intervention also looked really promising. So this showed a reduction in death or BPD at 36 weeks from 60 down to 42%. There was also not a statistically significant difference, but a small signal of less neurodevelopmental impairment in the intervention group rather than the control group. So both of these trials looked very promising and have shown some of the biggest decreases in BPD that we had seen, and they were longing for a couple of big randomised controlled trials. And so this led to the PLUS trial, which was Preventing Lung Disease Using Surfactant and Steroid trial, published in 2024 in JAMA. And this trial was led by Brett, who you will, I'm sure, hear from on the panel with many insights into this. But it was conducted between 2018 and 2023 in a multi-centre international trial in Australia, New Zealand, Canada, Singapore, and enrolled 1,062 infants with a slightly lower gestational age of 25.6 weeks and a smaller weight as well, with a median birth weight of 760 grams. Both the PLUS trial and the BIB trial, which we will speak about, both used budesonide with poractant alpha, so a different surfactant, and both were comparing the intervention of budesonide with surfactant versus surfactant only. In the eligibility for the PLUS trial, the infants needed to be less than 28 weeks, less than 48 hours of age, receiving respiratory support of some kind, and there was a clinical decision to provide surfactant. And infants were eligible if they had received no more than 1 dose of surfactant prior to being enrolled. The PLUS trial showed that there was no difference in survival without BPD between the control and the intervention groups, 25.6% to 22.6%. With the long-term follow-up, results have been completed and they will be available in the coming months. Unfortunately, given the promising trials before this, it was a bit of a disappointing thing not to see the silver bullet of budesonide in this. But at the same time as the PLUS trial was running, we also had the BIB trial start recruiting in the US. And just before we speak about the BIB trial, we'll also just say that Dr. Oei has also subsequently done a third randomised control trial, which has about 300 babies and has used Curacurf rather than the Surfactante used in the previous 2 trials, which has reportedly also shown some similar decreases on BPD or death, and that's yet to be published. And we're also aware that there are some other small trials showing a positive effect, mostly that have come out of China and Iran. And this is just the team that was involved in PLUS, showing what a large team it takes to get one of these big randomised controlled trials off the ground, as we see with the BIB trial as well. So for the BIB trial, what did the researchers do? So we're in a multi-centre, which is 17 centres in the US, a double-blinded randomised controlled trial that was conducted between 2021 and 2024. It used one-to-one parallel allocation to the intervention and control. They were stratified by study site and gestational age of less than 26 weeks or more than or equal to 26 weeks. Multiple births were randomised independently, and they used a step-forward randomisation protocol, which was where the data coordinating centre generated a randomisation schedule, and drug kits were then randomised, assembled, labelled, masked, and left at each site and stored in a location which permitted rapid access. And drug kits were added into the queue so that there were 3 or more available at each gestational stratum at any given time. And this was really a pragmatic and robust methodology, we thought, for this trial. They also required written prospective consent pre or postnatally, and infants were considered randomised once one of the drug kits were opened. And looking at this study design, the BIB trial included infants that were less than 29 weeks gestation or a birth weight of less than 1,000 grams, and had a decision made for surfactant in the first 48 hours of life. There was some exclusion criteria, which was if they had received a dose of surfactant or systemic steroids prior to enrolment, and that was a big difference between the PLUS trial and the BIB trial, where in the PLUS trial, infants were eligible to have received a single dose of surfactant prior to enrolment. Infants who had also been given indomethacin prior to the intervention, or there was maternal indomethacin prior to delivery, were excluded from the study with the pretense of the gastrointestinal perforations in previous steroid studies. The intervention, as we mentioned, was budesonide and surfactant, which used prolactin alpha versus the control, and the outcome was a composite of physiologic BPD or death by 36 weeks. And physiologic BPD was defined as receiving some respiratory support at an FiO2 of more than 0.3 or the failing a oxygen reduction challenge. And we felt this was a clear question that had been well designed and had comparable outcomes to the other major international trial. Power for the study was calculated at a baseline risk of BPD or death of 58% with 90% power, and that was to detect an absolute risk reduction of 10%, and that had a planned sample size of 1,160 babies. Unfortunately, the trial ceased at 55.3% enrolment, and that was due to a pre-specified futility criterion, and that criteria was at the upper limit of the 80% confidence interval for conditional power was less than 0.5. So really saying that there was less than a 50% chance of the intervention being successful if this trial was to continue past 50% enrolment. And by the time this futility criteria had reached, there was a total of 55% enrolment. And at the same time that this was being assessed, it's important to note that the PLUS trial was also being published, showing no difference in their findings. So to have a look at the flow diagram for the BIB trial, there were 5,353 assessed for eligibility, with 642 randomised in the end. And of that, 4,711 were excluded, mothers and infants. 2,167 were ineligible because they'd received either prior surfactant or did not require surfactant at all. And 24% of those assessed for eligibility declined consent, which is quite a large number at that 1,268. Approximately 2/3 of those had declined antenatally, and 1/3 of them had declined postnatally. The other reasons listed there, with 443 that were excluded, were things such as parents not being approached, not being able to make a decision in time, or other logistic barriers to consent. As clinicians, we would like to know the number of approached patients which would have been eligible, but this becomes very difficult with the antenatal consent process here. So as you can see, 642 were randomised, and then in the end there were 319 included in the intention to treat analysis for the intervention and 315 for the control. So who was in the trial? So these are some of the initial maternal demographics and characteristics. So there were no major differences seen here in either group between maternal age, race, health insurance statistics, or education level. There was, however, excellent antenatal steroid cover, with 88 versus 91% of these mothers receiving a full course of antenatal steroids, which is quite remarkable, and probably actually shows an evidence of often less urgent deliveries and maybe a relatively stable population of mothers where there was time to get a second dose of steroids into this population. There was also a high caesarean section rate, which is probably reflected in that same population, with 75% in both groups, and also a 40% histological chorioamnionitis rate, which was pretty comparable with other cohorts, including the plus cohort of babies. Some of the infant characteristics. So there was a mean birth weight of about 810 grams and a gestational age of 25.8 weeks. There were 42% of the infants were less than 26 weeks, so quite a good split there, and a 50% male and female split. There were also slightly more small for gestational age infants in the intervention group, with 19.3 versus 15.7%, but that was pretty comparable to other cohorts like this, with 15% SGA babies normally. So there were other infant characteristics. So those that were intubated in the delivery room was 60% of the babies, and that was pretty comparable between the two groups, and also similar data as in the plus cohort. 40 to 50% of the babies were mechanically ventilated at baseline. However, these numbers, where they report respiratory support at baseline, as you can see, they're missing approximately a third of the infants in the trial who didn't have this data available. It was mentioned that the babies who were missing the baseline data were often babies who'd received the intervention in the first hour of life. And so I'd expect that the number of IMV respiratory support at baseline would in fact be higher than this. And then in terms of a big pro to the methodology, which we spoke about before, about really ready access to the randomisation envelopes, was that they were able to have over 25% of babies had their first intervention administered in the delivery room. So to the primary outcome. Now, as you can see, there was no difference in the primary outcome of death or physiological BPD, both the combined outcome, but also when you considered them alone, there was no difference between the budesonide and surfactant or surfactant alone groups. In terms of secondary outcomes, BPD here was assessed by the Jensen definition, so slightly different from their primary outcome with the physiologic definition of BPD. And there was no difference seen in any of the secondary outcomes either. However, it was of note that there were still 10% of patients mechanically ventilated in that grade 3 severe category at 36 weeks postmenstrual age. And around 30% of infants required postnatal steroids after day 7, and that was pretty similar to the PLUS trial data as well. The BPD, they also looked at a whole lot of exploratory outcomes in this trial, and the BPD severity looked at here was the NIH definition, and there was still no difference seen between the two different groups of the intervention and control using these definitions. If you have a look at this data here, intubated after the treatment window, which is talking about patients that were unable to be extubated prior to the treatment window of 50 hours. So these are patients that remained intubated or who had a new intubation experience after this. And there was still 62 versus 68% of infants intubated after this, which potentially is due to chance in these exploratory outcomes. And there were also 4% of babies who required additional surfactant after the treatment window, which was not randomised to being either budesonide or not. There were open label surfactant usage. And just to very quickly touch on some of the subgroup analysis, which is demonstrated here, which looked at the difference in gestational ages, in chorioamnionitis, baseline oxygen requirement, sex and race. And as you can see here, it showed no difference in the subgroup analysis for these intention to treat population. Now, the strengths of the study. So as we mentioned, the randomisation allowed for delivery room inclusion, which is a real strength of this study and hopefully how it would be reflected in real life practice if something such as this was to come into generalisable practice. There was a comparable dose of budesonide and surfactant used to the other major international trial that has been reported, and the comparable dose of budesonide that's been used previously in other clinical trials. The methodology was robust and a strength, but also some limitations were that the intervention was with the first dose of surfactant. So it was great that it mirrored real-world practice if that intervention was to be in use. However, it was also a bit of a limitation, as that it meant that a proportion of more likely unwell babies were not able to be included in the study due to the inability to obtain written prospective consent for these patients. Some of the limitations of the study. So, as mentioned, written consent was required, as is standard in trials such as this. However, inherently this means that a proportion of otherwise eligible babies are not included in the study due to them being unable to be enrolled. The early trial termination, which led to a smaller sample size, which meant that the study was underpowered to see differences in the subgroup analysis. Only ETT surfactant was used in the BIB trial. There was no MIST or LISA allowed due to MIST and LISA not being FDA approved. And this just makes the study data a bit less generalisable in populations where other units are using quite a lot of MIST and LISA for surfactant delivery. And as previously mentioned as well, there was baseline respiratory support data missing for approximately a third of infants. And so it would be interesting to know whether they were intubated for the intervention or had they already been intubated prior to the intervention being required. And finally, what does this mean for me? So after looking at the BIB trial, we would say that adding budesonide to surfactant did not reduce bronchopulmonary dysplasia or death amongst extremely preterm infants, and that the routine use of this would not be supported outside research settings at the moment. It also highlights the importance of large multi-centre confirmation trials before adopting new therapies, as you can see the difference in outcomes between some of the smaller trials previously presented and these big randomised controlled trials such as PLUS and BIB. So thank you very much. I'll hand you back to Brett for an exciting interview.
Well, thanks, Lucy. That was a masterful review of the paper, and I hope you're all thinking about some questions or points you'd like to make in the chat. We've got some questions coming through already that we'll try and answer afterwards. So we're going to throw now to an interview with the first author, Dr. Ambal. I had the pleasure of interviewing him recently to hear his thoughts and where he thinks the results of the BIB trial sit in the context of clinical care. And when we come back, we'll have our panel to answer your questions and discuss all aspects of the trial. See you soon. Well, so pleased to be here with Professor Namasivayam Ambalavanam from the University of Birmingham in Alabama. Welcome, Ambal, to your friends and colleagues.
Thank you. Thank you for having me.
It's great to have you on Global Neonatal Journal Club to discuss your wonderful trial and paper. I'll just give a bit of background. You're the Virginia Walker Jones Endowed Chair Professor in Neonatology and the Program Director of the Neonatal Perinatal Fellowship Program at UAB. And you also run a lab as well as leading both single-centre, multi-centre, and in this case, very multi-centre clinical trials. And UAB is part of the Neonatal Research Network in the NICHD, and that's the network through which the BIB trial was run. So thank you again for being with us. Obviously a subject today very dear to my heart, having been part of the PLUS trial in Australia, New Zealand, Canada and Singapore. So I guess one thing as clinical trialists we always try not to do is stop trials early. So tell us a bit about how you came to the decision to stop the BIB trial early.
Yeah, so actually it was not my decision, but more the decision of the Data Safety Monitoring Board. They have a pre-specified interim analysis. I think after the first 40 patients are enrolled, then again after 25% and 50% and 75% and so forth. And after we had enrolled 50% of the patients, by the time they analyzed all the data, we were up to 55%. We found that basically, even if we had carried the study over to completion, we wouldn't see a significant difference. Basically, it met the stopping rules for futility. So it would have been futile to continue. We would have been spending a lot more time and money and exposing a lot of babies to an unnecessary treatment.
And so you'd enrolled, I think, 600 and something babies when the trial.
Yes, 641 out of the planned 1,160.
A bit over half of a trial that was planned to be similar in size to PLUS. And I guess you'd been pre-warned by the trial results of the PLUS trial, where PLUS had found no significant difference between the groups. But still, how did you feel when you saw the results of BIB? What were you hoping? And tell us a bit about how much work goes into these trials.
Well, I was a little disappointed. I anticipated the results would be somewhat similar to pluses, because I thought, well, we'll probably see between 3 and 5% absolute risk difference. I didn't expect it to be closer to 0. This trial had been in the works for a long time, I think from 2016 onwards. And then it took us a while to get the IND from the FDA and jump through all the regulatory hoops. And it takes a lot longer to get a study off the ground in the US. And I think in a way it's good that it stopped a bit early, because, if we had gone an extra year or 2, we would have enrolled more patients, but probably the results would not be any different.
One of the good things, of course, were that you and I and our teams were always chatting and trying to harmonise our outcomes and things to make individual patient data meta-analysis possible for the future, and that's something we're working on now. So between the PLUS trial and the BIB trial, the big question is this the end for intratracheal budesonide mixed with surfactant for extremely preterm babies?
I think it's the end for intratracheal budesonide with surfactant in this kind of population, meaning babies who are born in a referral center, who have been exposed to antenatal steroids, good antenatal care. It may not be as applicable to maybe babies who are born without all these characteristics, meaning that it's possible there are certain subpopulations who may benefit. Babies who are born without exposure to antenatal steroids, who come in and deliver quickly, and who are at higher risk of BPD, like Dr. A mentioned, with a much higher FiO2 than B, C routinely. So it's possible it might benefit some populations, but I think in most centers where you have babies exposed to, I would say almost 99% of them being exposed to antenatal steroids or good antenatal care, I think it's going to be probably not worth it to use this intervention.
You mentioned Dr. Ye from Taiwan, Professor Su Ye, who he's conducted now 3 smaller randomized controlled trials. We're still waiting on the publication of the 3rd such trial. But his first 2 trials, and then some other trials as well that have been included in systematic reviews, have found really dramatic improvements in survival free of BPD in extremely preterm babies. There are obviously some differences between his study populations and trials than our trials. The babies are slightly more mature and slightly larger for one. But have you got your head around yet why those trials have shown such dramatic improvements? We're talking about 30, 40, 50% reductions in BPD compared to the BIB trial and the PLUS trial.
Yeah, I don't think there is an easy explanation. I think it's, I really can't explain why we didn't see a difference both in the pluses or BEB. It's possible that, like you mentioned, the infants by Dr. A studies they're larger infants, but I think maybe less exposure to antenatal steroids. Maybe they're sicker to begin with a higher FiO2. So it's possible they're slightly different. And it's also likely that there are big differences in terms of center practices. We all know there are large differences between centers and the rates of BPD, which are to do with how babies are actually being managed. We all know that if if you take two centers and they have the same rates of surfactant use or CPAP use, but still the rates of BPD are different because how people use CPAP and when they decide to give surfactant might be different.
So you mentioned BPD in both of our trials. That was defined at 36 weeks post-menstrual age, as it is in most clinical trials in neonatology. What do you think about that as a key outcome for ongoing trials?
I think BPD is a good operational definition, meaning that it's something you can define in almost any preterm baby. However, it's not a very accurate or precise indicator of the magnitude of lung disease, and it doesn't really tell us what exactly is the problem with the lung. I mean, we know that, yes, there is the inhibition of lung development, there is some parenchymal injury, there is some airway malacia, there is some pulmonary hypertension, there are abnormalities in control of breathing. But then we have chosen to just rely on one metric, which is how much oxygen is the baby on at 36 weeks. And that's, I think, a good short-term outcome, but it doesn't really predict longer-term outcomes very well. And like I mentioned, there's a lot of intercenter variability based on how people practice that affects this outcome too. So it's a reasonable short-term outcome, but I don't think it really can be extrapolated beyond, say, early infancy. I mean, we really need better markers of long-term respiratory outcome.
Well, Ambal, it's been so fascinating to hear your insights from the BIB trial. We will enjoy reviewing it and discussing it now in our Global Neonatal Journal Club. Thanks for coming along. I look forward to collaborating with you and combining our trial data as well as with others to see if we can find any infants, as you mentioned, that may, or subgroups that may benefit from intratracheal budesonide. But for now, the jury's out. So thanks again for coming along, and see you soon.
Thank you. Nice to talk to you.
All right, that was. Here we go.
Yeah, we're echoing a bit, aren't we? Okay, Neena and Peter.
There we go.
Is it just me or is it everyone?
Let's see if that works. No.
Okay, just say hello, Neena and Peter, and we'll just test your sound.
Hopefully this works. Perfect.
That's better.
Thanks,
That's better.
Bella, for the
Hi there.
Media tech support.
Okay.
Can everyone hear me?
Yeah, it's good now.
Great.
Yeah.
Perfect. So that was a really awesome overview of the trial. Lucy, thanks very much. Really good to understand some of the details of how the trial was conducted, some of the strengths and limitations and the trade-offs that trialists often have to make, and fascinating to hear from Prof. Ambal as well. It's time for panel discussion now, and we'd love for you to share your own thoughts and questions in the chat, and we'll try and pull those together and put them to the panelists. But let's start off by, obviously, it's great to see Professor Neena Modi and Professor Dargaville back on the screens. Our first question goes to each of you, and perhaps you could take turns in answering the first question, which is quite broad, and it's really to ask you, really, what were your thoughts on the paper?
Neena, why don't you start?
Ladies first.
Peter, you took the words out of my mouth. It's good to see you, and I was going to suggest you go first, but hey, let's not quibble about it. Well, thank you very much for inviting me to be on this, and thank you to Lisa for a great summary. But congratulations, first of all, to Prof. Amber, but also to you, Brett, because the two of you have both conducted a really two really high impact, and we'll talk about the impact in a minute, but high quality trials. So you could say, yeah, I agree with you. The jury's out for the moment. So you use that phrase, Brett. The jury's out, which suggests that you don't feel that the decision's definitive. And I guess this brings one to the question of where are the gaps? These are two really good, robust trials, but where are the gaps? And I guess the first thing is a very high-level observation, and that is that BPD is not a unified diagnosis. It's a ragbag, it's a hodgepodge, isn't it? And it may be that we are digging a hole for ourselves in neonatal medicine because we've created this entity called BPD, but BPD is a very heterogeneous condition based on some very variable and slightly arbitrary criteria. It's not a unifying diagnosis at all. And therein may be a big problem because it means we're not able to stratify our patients on the basis of the specific pathophysiological abnormalities that are contributing to these babies' illnesses. So I think we have got a major problem there. But let me put that to one side because we're not going to solve that issue in the course of the next few minutes. Specific points about the studies are, and I think this relates mainly to the US study. I always get slightly irritated when I see eligibility criteria based on both gestational age and birth weight. I think that's conflating two separate parameters. And if we're thinking about immaturity, I'd suggest that you stick to gestational age. Their inclusion criteria were 22 to 28 weeks or 401 to 1,000 grams. And I think they would have done better to have stuck to the gestational age eligibility criteria. And then if they wanted to, they could have stratified by birth weight Z-score, for example. But that's a methodological comment. I'm glad to see that both of you randomized multiple births independently. That's great. I think that's respecting the individual autonomy of babies. So well done. This can be a slightly controversial area with many trials randomizing multiple births as a single unit, which I don't think respects the autonomy of the individuality of a baby. So well done there. I was intrigued that neither of you stratified by sex. And that may be something that you want to bear in mind when you hopefully get round to doing your IPD, because it may well be that there are differences in relation to sex. And then I think a really important point, particularly given that we've got a global audience for this, is that these were two studies in high-income settings. And of course, there's a huge burden in low and middle income settings. And it would be good for us collectively as a global neonatal community to think about how we can design our multinational trials that include babies from low and middle income settings. And Brett, I know you and I have both been thinking about this in relation to international platform trials. And I'd like to introduce this concept, even if only at a high level, to our global audience. But let me stop there and let's bring Peter in.
Thanks, Neena. That was great. I want to focus on a few of the practicalities and consider whether it's really possible that a single dose, or in about a third of cases, 2 doses of this drug, budesonide, administered at a very early time in a baby's life and not followed by any more steroid delivered directly to the lung, could possibly be expected to make a significant difference to a chronic disease many weeks later. And that's always been my concern and indeed my skepticism about whether using budesonide in this way, with all the elegance that comes with delivering it with surfactant, could possibly be that magic bullet. And it's important to note that the dosage used in the PLUS and BIB trial was exactly the same per kilo on average as in Oei's study, or at least the one that I'm aware of. Given at slightly later time in both the PLUS and BIB, where it was given on average first dose at 4 hours compared to about 2 hours in the Oei studies. And it really does raise the question of how much of the steroid gets delivered. The mention was made of using minimally invasive surfactant therapy to deliver surfactant and indeed budesonide, which happened in, I think, 14% of plus babies, but none of the bib babies, as we heard. That could make a little bit of difference because it's likely surfactant's better distributed, more evenly distributed to different parts of the lung using that approach. And maybe that would lend an advantage, but there weren't enough cases in plus, I don't think, to make a separate analysis of that. And the other thing to say is that looking at the dosage used, say, for example, in the neurosis study, which was using a steroid vial inhaler, the cumulative dose given there, I've just done a calculation of that, was around about 40 milligrams per kilo delivered. Obviously, only a tiny fraction of that ends up in the lung. But that's actually a lot more steroid than you can possibly deliver this way. Last thing to say is that it was curious that the dose preparation or the preparation of the budesonide was different in bib, more dilute, which meant that actually the surfactant was quite diluted by the budesonide because that was a 1 mil per kilo dosage of budesonide compared to 0.5 mil per kilo with each dose in plus.
Okay, I should go now. So, why? Maybe I'll ask either Neena or Peter. Why do you think there was so much difference between the Oei studies and these two large trials? Peter, I guess you're still unmuted.
Yeah, well, Prof. Abels alluded to some of the differences in the study populations. And one has to say that when alluded in particular to the fact that maybe the infants in the Oei studies were sicker and therefore more predisposed to have an inflammatory lung disease be kicking off at that time. However, you have to say that when there have been subgroup analyses done in bib and in plus, looking at the babies in 50% oxygen or more versus those in less oxygen. For the bib trial, there was no sign of a signal there. For plus, there was a little bit of a signal there with a p-value for the interaction of 0.07. And that's something that will need further exploration in the individual patient meta-analysis for sure, is that. Other than that, it is difficult to reconcile the findings. I don't have a particular explanation.
Yeah. Yes, thanks, Julie. I mean, we know that this, results do arise by chance. When we're designing trials, we're talking about the probabilities. We're not talking about absolutes. And fluke results do arise by chance. There may be genuine reasons. Patient population might be different. The trial methodology might be different, et cetera, et cetera, et cetera, et cetera. So there may be genuine reasons for differences. But this is a danger of small trials. Small trials, of course, typically don't have power to detect a finding when there is a finding there. What we've got here is the converse. But that too could arise by chance. And this is why it's really important that we don't change practice on the basis of small trials or even single big trials. And I think the great thing that we've got here is we've got two big high quality trials, both of which are telling us the same thing. There are questions, as Peter rightly says, about dose. There'll be questions about timing of administration, and there'll be huge questions about the selection of subgroups. And that brings up a really important other issue for perinatal medicine, which is, are we able to bring precision medicine approaches, or are we still stuck in the days of doing big blunderbuss large trials with where we're looking for average effects across an entire population? And I would really like to see us being able to use all of the very sophisticated omic technologies, starting with genomics and going into every other omics, to try and define our patient population much more precisely so that we can actually target subgroups in a much more sophisticated way. So I agree with you, Brett, that I think the jury's out for the moment. I don't think there's going to be another big budesonide and surfactant trial that funders would be willing to put their hands in their back pockets to support. But it does mean the basic scientists in our field going back to the drawing board. And it also means, I think, that we're going to look with great interest at the IPD that you hopefully will be doing to see whether that affords any clues. Last point I want to make too is that, and it's a pity that Amber isn't with us here, because he kind of ducked the question about why they stopped. And there is a controversy about stopping for futility. Now, this is usually done in pharmaceutical trials. It's not normally done in these sorts of clinical trials because, of course, if you do continue, you do get a tighter, you do get tighter precision on the confidence interval, not only for your primary outcome, but also of great importance for all your secondary outcomes, which can be very helpful if you're thinking about, why did this trial not show anything definitive? And if you're thinking about that next very carefully targeted, carefully focused trial. But I'd like to throw a question back now at Brett and say, isn't the challenge also about doing this in a low-income setting with all of the differences in patient characteristics and ancillary treatments?
Yeah, thanks, Neena and Peter. I mean, just wonderful introductions to the discussion, and you've really hit on a lot of critically important points here. I totally agree, Neena. I guess we're talking about extremely preterm infants, so we'd have to be thinking about which countries could be part of a trial who routinely look after tiny babies. And, in the PLUS trial, we were enrolling infants down to 22 weeks, and similarly in the BIB trial. So it might be a slightly more mature population that we'd want to look at in low and middle income countries. But I totally agree, we can't extrapolate these results to other settings or populations, and I totally take that on board. I think the other thing, you've discussed a lot of the issues with small trials and how they can lead you down the garden path. I mean, the other thing we're facing as academics and researchers is this problem of combining all of these small studies and their ability to overwhelm even large trials in systematic reviews. And we're seeing this already. There's been several, too many, of course, systematic reviews already published, including the PLUS trial, where there are another 10 to 20 small trials all showing a benefit, and they even seem to have the ability to outweigh the PLUS trial. So we've got the age-old question of what do you believe? Do you believe a whole lot of little trials put together, or do you believe one or two large, robust trials? And I know what my answer is, and obviously the IPD-MA, the individual patient data meta-analysis, is going to be very important for that reason. In several respects, putting the data together and looking at some of these subgroups with more power, which we've always planned, but also in the selection process for the IPD-MA, we'll be asking the investigators and the trialists of all these trials to share their data and let us have a look at that. And, we'll be making sure that only very robust studies are included in the IPD-MA, which may take away from some of those concerning effects of smaller trials. I think we'll throw now back to Shiraz because we've got questions coming through on the chat that he definitely wants to get to.
Yeah, and I'll bring in some of the thoughts that Neena alluded to here as well, specifically relating to subgroups, but also to studies in low and middle income countries. So Vinayak and Elif online were asking him particularly about the subgroup of infants born in the context of choriamnionitis neonitis. Elif points out that the WHO recommendation is to not administer antenatal steroids in the setting of acute choriamnionitis neonitis. And in these trials, we have babies recruited who were born in that setting and are now given intratracheal steroid. So it'd be good to get some thoughts on the importance of looking at that subgroup and how we progress that specific question, both in our setting but also in more in settings around the world. Perhaps I can start with you, Peter.
Well, the first thing to say is that there was a subgroup analysis based on choriamnionitis or the absence of it in both PLUS and BIB, and in neither case did it show any signal to suggest that either having chorio or not rendered you more likely to gain benefit from budesonide.
And I might just add there, Peter, the reason those subgroup analyses were in there, of course, is that in some of the other steroid trials, and we're talking mainly about systemic steroid trials, but also the neurosis trial, there did seem to be some benefit in patients exposed to choriamnionitis, and that's certainly something we were interested in and found absolutely nothing, as you say. And another pre-planned subgroup analysis within the IPD-EMA, I might add.
Yeah, recognising the difficulties in the definition of chorioamnionitis, of course, in some of the studies. I'm sure there'll be different definitions.
So can I ask a question? Sorry, Neena.
Sorry, no, I was just going to, Peter took the words from my mouth. I mean, it begs the question that we've got a problem with the definition of chorioamnionitis as well. A huge problem. So even if we were to be able to do subgroup analyses or stratified trials, we've really got to I think we've really got to face head on the problem of, again, definitions. And if I could just add another point, because we've not raised this yet, and that is that there is a long and not terribly edifying history in neonatal medicine, because we're all such enthusiasts. We all want to rush to do the randomized trials, that maybe we sometimes don't spend enough time getting the basic science right. And translational research should really be founded on some very good preclinical empirical evidence, and that's not always necessarily the case. Now, this is not my area of expertise at all, so I turn to all of you to say, do you think that the preclinical work actually was sufficiently, from my understanding it was, but I'm happy to be told no, that the preclinical work was absolutely robust, both in terms of the idea of budesonide plus surfactant, also in relation to the dose of budesonide? Or do you think that we need to go back to the drawing board a bit?
Yeah, well, the PLUS trial was designed in the context of quite a lot of preclinical and clinical evidence and biological plausibility. There are many studies, animal studies, looking at that combination and showing beneficial effect on inflammation and various other factors in those animal studies. And Oei himself has been part of those and also looked at the distribution and the concentration and the dilution of budesonide within different ratios of surfactant, and went ahead with his trials. And then, of course, we've had these his 3 trials and others showing this huge benefit that needed to be confirmed. So I think our feeling was at the time that that combination of preclinical plausibility and clinical evidence was enough to go ahead with the larger trial to really show whether this was, to show definitively whether we would see such a benefit. What do you think, Peter? What do you think, Peter?
Well, yes, I agree with what you've just said, but the fact is glucocorticoids are a bit of a blunt instrument, aren't they? And surely, I think you're alluding to the fact, Neena, that surely we can come up with drugs that aren't quite so all-encompassing in their effects. You could argue that ciclesonide, which doesn't have the neurological effect, might be a drug to take to clinical studies. And surely we can do better than just glucocorticoids alone and use more targeted therapies against the precursors of inflammation.
And again, I would say that therefore calls for a much more precise understanding of the pathophysiological basis of what we're calling BPD, because clearly there are multiple different elements involved. Inflammation is one, athletics is another, pulmonary immaturity is a third, and so on and so on and so forth. And of course, the combinations of those, the pathophysiological determinants in each individual baby is going to vary. So until we can actually stratify our patients in a much more sophisticated way than we're able to do now, on the one hand, and then I completely agree with you, steroids they're blunderbuss therapies, aren't they? They do everything, make your hair grow, they do absolutely everything. So terribly blunderbuss therapies. So we're not going to be able to get to targeted treatments for our babies until we, 1, can break down the determinants, the causal determinants, and 2, find drugs that are targeting appropriate elements of such a multifactorial disease.
I've got a further question, perhaps directed first to Neena, and this relates to consent, so prospective parental consent. Should we always seek prospective consent for drug trials, particularly when the drug in question is not used routinely in clinical practice for the specific purpose?
No, I'm not quite sure I understand the question, because I would say that that informing parents and getting consent for any research study is essential. It's also pretty essential when we're practicing clinical practice. So forgive me, I'm not quite sure what the underlying basis of this question was. Is it specifically about drug trials as opposed to other trials? Is it about prospective consent? Is it about consent in general? It'd be good to hear from the person who asked the question. Forgive me, I don't see it in the chat.
It's not a question, Neena. I think it's just something that Shiraz was asking you about.
Shiraz, what's in your mind?
Yes, so I suppose it was a follow on from some of the thoughts that we had reviewing the paper in terms of the limitations where a trial that can only recruit participants where there is enough time for prospective parental antenatal consent or consent shortly after birth cannot be a fully representative trial of the target population. It is not entirely generalizable to every patient that we as clinicians see every day. And for us to do the trial that recruits every patient that we would typically be potentially given the intervention to, we would need to broaden our models of consent. And you've argued this case very well in multiple forms, Neena. So I suppose my question comes from that angle. Clearly strong arguments have been made for alternative forms of consent where the intervention is routinely used in practice, and perhaps there's practice variations between centers, but particularly when it comes to drug trials and drugs that aren't routinely used in practice, is there any way we can try and do the trials in a different way such that the sample that we recruit is more representative of the bigger target population?
Yeah, no, thank you for clarifying, Shiraz. I understand now. Thank you very much. And that's a really important set of questions that you've asked. So I'd answer it like this. In the provision of information to parents and the obtaining of their consent is an evolving field. And parents need to be part of this debate. Now, I think Brett said earlier on that some centres, on the basis of the initial small trials, have incorporated budesonide into their routine practice already. Okay, so let's just think about those neonatal units and then think about those neonatal units who haven't incorporated it into their routine practice. For the latter, this is still a research question, an experimental study, a drug study as well. For the former, if there's any doubts about whether or not incorporating this into their routine practice is beneficial to babies or not, I think it's legitimate for them to say, well, some of our consultants don't use budesonide and some of our consultants do. And therefore, what we're going to do, rather than leave it to the biases, the individual biases of individual clinicians, what we're going to do is inform our parents that what we're doing is randomizing all of our babies. Now, if you have time, you can ask parents to opt out of that. That's the opt-out consent model. If there's a real urgency about getting in there and randomizing quickly, then you can also make the case, and it's for the investigator and the clinician to make the case. You could say, actually, it's perfectly legitimate and in the baby's best interests to receive this treatment on the basis of randomization, because there's still a query about its efficacy, and because some of us are doing it routinely anyway, and some of us are not. So that's a model that should be explored with parents, because they will probably see the rationale for that. And if they do agree with the rationale for that, then you've got a way forward. Going back to those units where it's still not used in routine practice, again, you've got a number of different approaches. And I would say at this point, discuss these different approaches with parents and see what they think is best, because they will probably give you the best advice and say, okay, we want to go for deferred consent. Okay, we want to go for information first and then consent later down the line. Oh, okay, we want to go for this model or that model or the other model. So I do think that, and again, I say this to your international audience out there, ethics and information are not immutable. they're evolving, and they're evolving as we understand what's most beneficial for our babies. And I would say that in many, many circumstances, protecting babies from the biases that we all have, the biases of clinicians. We think, oh, I think this is right. Oh, I think that is right. Protecting our babies from our own inherent biases, and where it's appropriate, selecting treatments on the basis of randomization should become a standard of care. And in 10 years' time, if we're all still around then, let's look back and see whether randomization is the default standard of practice in many situations. Anyway, thank you for raising that, Shiraz.
Fantastic answer, Neena. Just looking at the time, we're running out of time. Peter, did you want to add anything to that response?
Only to say that I think whether deferred consent can be considered an option has to take account of whether it's a superiority trial rather than a non-inferiority trial, and what's the outcome of interest. And in the case of the BIB and Plus trials, it was death, and there was the possibility that there'd be a difference in that outcome, and that to me does make a difference in how I perceive using deferred consent.
Thanks, Peter. Julie, did you have?
Yeah, could I ask you a question, Brett? There's a comment on the chat pane about timing of the dose of budesonide. What do you think of that? Dr. Oei seems to have given it earlier.
Yeah, thanks, Chuck. Lynn's asked that. Thanks, Chuck. Yeah, and Dr. Oei said the same thing to me. He thinks that the difference in effect is largely down to the timing of the intervention, and we acknowledge that on average babies got it slightly earlier in his trials than in either Plus or BIB. Of course, there was a significant population in the BIB trial that got it very early because of antenatal consent and delivery room intervention. So whilst not all babies did, they on average there was a bit later, but there was certainly a significant number that did get it very early and earlier than in the Plus trial. And again, no signals there. So I'm not sure about a couple of hours difference on average. I mean, Chuck makes the good point about some of the physiology involved there, and perhaps getting it in before you do anything else to the baby and true prophylaxis may be an important way of doing it. And I think we alluded to that if this did work and came into clinical practice, I suspect many of us would be giving it in the delivery room or very soon afterwards, and sooner than it was given in the clinical trials. And one of the reasons for that is, of course, the need for prospective consent in the clinical trials, and certainly was a factor in the Plus trial. There was also some questions. I think Gayatri Jape, who's here, thanks. Hey, Gayatri, asked about possible ethnic or genetic or epigenetic differences in the trials. And that, of course, is something that we can see. I think in the Plus trial, the Asian population was around 15 or 20% of the total population, whereas much higher in the trials from Taiwan, and similarly from other smaller trials out of Asia. There are some ethnic differences, and we've certainly seen publications looking at differential effects from drugs in different populations. So, these may be contributing, but honestly, when you put it all together, I'm not sure that they've made such a big difference to the outcomes. I mean, we're talking about a 50% reduction in BPD versus no reduction in BPD. To me, that seems a little bit hard to believe.
That's a big difference. Yeah. So what would you do in your daily practice now, Brett, while you're waiting for more information to come out?
Well, as blunt as these big trials are, or pragmatic, I guess, is a word I use often. I'm not going to be using this in my standard practice, and I know some of the centres in the US that have been based largely on the preclinical trials and then Oei's early studies are reconsidering that. But we'll see what comes out of the IPDMA, and that may lead us, in some directions. And as Neena was alluding to, maybe there are a little bit of individualised medicine that can happen here. Maybe we'll see some signals in the IPDMA that lead us on to another trial.
Yeah, so the conclusion to the question of whether budesonide and surfactant is, I suppose it's a date therapy, yes or no?
Well, for me, it's a no.
Okay.
And again, with the caveats as before, perhaps we can end with Peter, your thoughts. Is this the end for this intervention?
I think it probably is, but we should say that Plus and BID presumably are going to report on follow-up outcomes, and there might be something in there that comes out in the wash-up.
Yeah.
Yeah. So we should wait for that. And in the case of PLUS, it's not too far away.
Yeah, that's right. We finished the follow-up at 2 to 3 years. I think we've got about 92% follow-up primary outcomes for all of the babies in PLUS. So we'll be hopefully have some results in the coming months. Neena, did you want a final comment on that question of is this the end of intratracheal budesonide mixed with surfactant?
Well, for the moment, yes. But, science is not immutable. There's no certainty. There's only ever decreasing uncertainty. So let's watch this space, and we all look forward to, your IPD and your follow-up outcomes. And once again, many congratulations on a well-conducted trial.
Well, thank you. That's a good place to finish up. Thank you to the 100 and something odd of you that were joining live, or at least 100 and something individual logins. About 500 people registered, so you might be watching this later on, and thanks for doing so. Big thank you to Professor Peter Dargaville and Professor Neena Modi. Really appreciate you joining us, and that was a fantastic discussion. You really put a lot of thought into that, so we really appreciate that. Thanks to Julie and Shiraz. Thanks to Bella, who's sitting next to us for all of the organisation, and of course thanks to Lucy, who's sitting across from us for her fantastic review of the paper. And we'll see you all next time. Bye for now.
Thanks very much. Bye-bye, everyone.